Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO!
Hi, everyone. In today's episode, we're going to be covering Gestational Trophoblastic Neoplasia, or GTN. Sydney, what are our learning objectives?
Our learning objectives are to distinguish between gestational trophoblastic disease and gestational trophoblastic neoplasia, to discuss the difference between FIGO stage and WHO prognostic score in GTN, to compare the two most common single-agent chemotherapies used in low-risk GTN, methotrexate and dactinomycin, to recognize the importance of continued follow-up with serial HCG assays and contraceptive counseling, to compare the treatment regimens for high versus low-risk GTN, and to discuss unique characteristics and considerations for intermediate trophoblastic tumors compared to invasive mole and choriocarcinoma.
Gestational trophoblastic disease encompasses a group of benign and malignant tumors that develop in the uterus from placental-like tissue. These can be related to previous molar, intrauterine, or ectopic pregnancies. Complete and partial hydatidiform moles or molar pregnancies make up benign GTD, although they're considered pre-invasive as they have a risk of developing into a malignancy. Gestational trophoblastic neoplasia describes the malignant subtypes of GTD and includes invasive mole, choriocarcinoma, placental site trophoblastic tumor or PSTT, and epithelioid trophoblastic tumor or ETT. Let's start, as always, with some epidemiology. The incidence of GTD is variable by region. In the US, a rough estimate is 1 in 1,000 pregnancies that have some type of GTD. There's a higher incidence of reported GTD in Asia than there is in Europe and North America. While we don't know exactly why this is, it may be partially due to cultural patterns of pregnancy care. For example, there might be less documentation of normal pregnancies due to home births and non-reporting of abortions, driving a higher incidence of reported GTD. 80% of all GTD are made up of hydatidiform moles or molar pregnancies, either complete or partial. Invasive mole, a form of GTN, makes up 15% of GTD, and the remaining subtypes of GTN make up the last 5%. Sydney, can you remind us of the differences between the types of moles and ways that they present?
We don't want to spend a ton of time on benign GTD, but as gynecologic oncologists, we are the experts of this disease, so we'll often be helping our generalist colleagues manage complex cases. So let's talk about some specifics. Remember that complete moles are formed when an egg without maternal DNA is fertilized, while partial moles come from normal eggs fertilized with either 2 sperm or an altered sperm. Complete moles are diploid, while partial moles are triploid. Remember that complete moles have no fetal tissue and have a snowstorm appearance on ultrasound, while partial moles can have varying degrees of fetal tissue. Pathologists use a variety of features to distinguish between molar subtypes, but there is some inter-observer variation. P57 staining can be helpful to determine the etiology. In complete moles, P57 staining will be absent, while in partial moles, P57 will stain positive. Additionally, some pathologists will use molecular genotyping, like short tandem repeat STR analysis or flow cytometry, to help distinguish between complete and partial moles. Complete moles have a higher rate of developing malignancy. Postmolar GTN develops in about 15 to 20% of cases, while in partial moles, this risk peaks around 5%. Despite earlier diagnosis of molar pregnancy due to more frequent earlier ultrasounds, the rate of postmolar GTN has not gone down, which indicates that the malignant potential of moles is more related to intrinsic properties of the mole rather than duration of gestation. Types of molar pregnancies also tend to present in different ways. Complete moles, given their higher HCG values, are more likely to have the classic symptoms of molar pregnancy, like hypertension, size greater than dates, increasing nausea or vomiting, abnormal bleeding. Partial molar pregnancies are more likely to be diagnosed incidentally and tend to have lower HCG values and may present later in the pregnancy. Often these are diagnosed on pathology after a presumed miscarriage. Maya, I know that suction, dilation, and curettage is the most common management of molar pregnancy. Can you walk us through the nuances of when other options might be preferred?
Yes, surgical management is the key to effective treatment of molar pregnancy. And you're right that the majority of the time, this is accomplished via suction DNC, followed by serial HCG monitoring. There are times, however, when doing a hysterectomy with bilateral salpingectomy may be a preferred treatment. Specifically, this is preferred if patients have completed childbearing, if they're likely to have a complete mole, and if they have risk factors for postmolar GTN. Factors like very high HCG, greater than 100,000, markedly enlarged uterine size, large theca lutein cysts indicate aggressive trophoblastic growth and are a risk factor for GTN, as is age greater than 40 years and signs of myometrial invasion on diagnostic imaging. Medication management of molar pregnancy is not recommended. Emerging data is suggesting that certain labs, based on microRNA or DNA methylation status, might be more reliable in predicting the risk of GTN development than our clinical assessment. Be careful with interpreting the HCG if it's really high. The hook effect describes the phenomenon where people with extremely high HCG levels, like greater than 1 million, may have a negative HCG assay. The detection antibody is supersaturated with the antigen, which is the beta HCG, so the antibody test fails. Dilutions of the sample can be done to prove this. And additionally, HCG molecules associated with molar pregnancies and GTD are different than those in normal pregnancy. They can take slightly different forms and be more degraded than in a normal pregnancy. So it's important that we're using HCG assays that can pick up all of these forms of HCG to get an accurate level. Sydney, can you review any special management considerations prior to and during surgical management of molar pregnancy?
Preoperative labs, including a type and screen and HCG level, should be done for all patients. For patients presenting later, at higher risk of complications from a molar pregnancy, thyroid labs and labs for preeclampsia should be ordered. A chest X-ray should be performed for all patients with pulmonary symptoms, and many include a chest X-ray routinely. If patients have hyperthyroidism, it's important to treat them with a beta blocker prior to surgery to manage symptoms related to thyroid storm. Those can include fever, hypertension, tachycardia, and potentially ARDS. Rh-negative patients should be treated with RhoGAM. During a DNC, ultrasound guidance is recommended to make sure all products are evacuated and to help prevent uterine perforation. Oxytocin is typically administered to promote post-evacuation myometrial contraction and limit blood loss. If performing a hysterectomy, either at MIS or open approach can be done. A rare postoperative complication of molar evacuation is the risk of cardiopulmonary symptoms, specifically respiratory distress syndrome. This is typically due to trophoblastic embolization, but can also be the result of thyroid storm. Management is supportive with respiratory support. Symptoms typically resolve within 2 to 3 days as the HCG levels decline. Maya, we mentioned that the rate of postmolar GTN hasn't really declined despite earlier diagnosis. Is there anything we can do to decrease the risk of postmolar GTN?
Unfortunately, no. Prophylactic adjuvant chemotherapy has been used and studied as a way to decrease the risk of GTN, but it hasn't seemed to make a significant difference. A Cochrane review published in 2017 reviewed 3 randomized controlled trials that evaluated this question and concluded that in general, there wasn't sufficient evidence to recommend prophylactic chemotherapy. This review and the NCCN guidelines both state that prophylactic methotrexate or dactinomycin can be considered for those patients that we described as being high risk for development of postmolar GTN. Prophylactic chemotherapy is typically not utilized for patients treated with hysterectomy, as this procedure itself reduces the risk of postmolar GTN. Sydney, what's the schedule for HCG follow-up after treatment of molar pregnancy? And when do we diagnose postmolar GTN?
Specific protocols can vary slightly by institution, but we'll discuss a generally acceptable strategy here. Typically, weekly HCG levels are measured until undetectable and then monthly for 3 months in the setting of a prior complete mole. If the molar pregnancy was a partial mole, given the lower risk of GTN, it's acceptable to obtain HCG levels weekly until undetectable and then obtain one HCG level in 1 month. During weekly HCG monitoring, levels should fall by greater than 10% with each measurement. If these levels fall appropriately and stay undetectable, monitoring can be discontinued and patients can reattempt pregnancy if desired. There are 2 scenarios in which postmolar GTN is diagnosed. One is when HCG levels increase by greater than 10% across 3 values during a 2-week period, and the other is if there is a plateau, for example, remains within 10% across 4 values during a 3-week period. I always remember this because a rise is more concerning than a plateaued value, so you need less rising values to diagnose GTN than plateaued values. Anything that doesn't yet meet this criteria is not yet GTN, and we need to keep monitoring until a definitive diagnosis is reached. Previously, postmolar GTN could also be diagnosed if HCG was persistently elevated 6 months after initial treatment, despite appropriate drops, but this has been removed from the guidelines, as several studies have shown that avoiding chemotherapy may be reasonable in this population as long as continued surveillance is followed. Maya, can you tell us about other reasons why HCG levels could be elevated in our patients? Essentially, some other less common differential diagnoses?
Definitely. So the first one, which seems obvious, but we can't let it fall off our radar, is a new pregnancy of any kind. Once you've ruled that out, there are some rare but important etiologies to consider. The first one is called quiescent GTN, which I had personally not heard of before making this podcast. Quiescent GTN is a phenomenon that can occur during and after the treatment of GTN or a non-molar pregnancy, in which HCG levels stay persistently elevated for at least 3 months after evacuation of a mole, in the absence of any other detectable disease. As we've discussed, a plateau in HCG levels is how we diagnose postmolar GTN, but sometimes when these levels are persistently low and are less than 200, it can be due to quiescent GTN. While most patients with quiescent GTN do not develop invasive GTN, up to 10% of them do. So they require monitoring with monthly HCG and avoidance of pregnancy. Sometimes the quiescent GTN diagnosis will come after you diagnose a postmolar GTN based on a plateau, and you see chemotherapy resistance with persistently elevated HCG levels. Again, only if they're low, less than 200. If you see no other signs of disease in this scenario, chemotherapy can be discontinued and ongoing HCG surveillance can be started. Quiescent GTN is thought to be due to small residual syncytial trophoblast foci without cytotrophoblasts. A way to support the diagnosis of quiescent GTN is through measurement of hyperglycosylated HCG, which is produced predominantly by the cytotrophoblast. So in quiescent GTN, these levels should be less than 10% of your total HCG. Elevated HCG can also occur in peri- and postmenopausal patients or in patients undergoing chemotherapy in whom the ovaries are suppressed. This phenomenon occurs due to removal of the ovarian suppression of the hypothalamus pituitary axis. When the ovaries are shut down for any reason, production of LH will be upregulated. Because HCG and LH are both made in the anterior pituitary by genes that are close together, and because they share their alpha subunit, low levels of HCG get produced at the same time. So these levels will stay low with a maximum of about 25. The way to assess for this as a cause is to either measure LH levels. If they're elevated near menopausal levels, then that would support the diagnosis. Or you can administer estrogen to suppress pituitary production of LH and see if the HCG gets suppressed as well. Sydney, I think there are a couple of other causes of elevated HCG that aren't part of the GTN spectrum. Can you tell us about them?
Yes. So, the last cause of truly elevated endogenous HCG is to cover familial HCG, which is a very rare genetic condition in which HCG, both urine and serum levels, are elevated for many years, maybe throughout the whole life in patients. These will be low levels, usually 10 to 200. This is a diagnosis of exclusion, which really only should be considered when you rule other things out. Testing first-degree family members, male or female, is a way to support the diagnosis. Heterophilic antibodies are another cause of elevated serum HCG. You may remember this one from studying for creogs in residency. These are antibodies that occur in humans and interfere with antigens included in some immunoassays. They can cause a false positive HCG level. These are becoming less common as modern immunoassays have incorporated technology to decrease the incidence of this phenomenon, but good to still keep on the differential. The way to test for this is to measure urine HCG. If the serum HCG is elevated due to heterophilic antibodies, the urine HCG will be negative. Maya, once we evaluate our patients and reach a diagnosis of GTN, what is the evaluation that we should perform?
As always, an H&P is performed. Signs of postmolar GTN include vaginal bleeding, persistently enlarged uterus or ovaries, or rarely vaginal nodules. Do not biopsy the vaginal nodules because they can bleed excessively. GTN after other pregnancies, like non-complete moles, often has abnormal bleeding and is less likely to have enlarged uterus and ovaries. Any metastatic disease sites will present with symptoms specific to that organ system. GTN should be considered in any reproductive age female patient with unexplained HCG levels, even if there isn't a clear antecedent pregnancy. Remember that these can occur after early or undiagnosed pregnancy losses, so many patients may not be aware that they had a pregnancy. In the setting of no previous molar pregnancy, an elevated HCG without any other explainable cause is enough to diagnose GTN. While findings of metastatic disease or enlarged uterus support the diagnosis, they're not required. Finally, recall that HCG can be elevated in some germ cell tumors of the ovary, and a rare subtype of germ cell tumors of the ovary is non-gestational choriocarcinoma. Labs for your workup again should include a type and screen, a quantitative HCG, CBC, CMP, and a TSH. Imaging with chest X-ray is always done. If there's no evidence of vaginal or chest metastases, imaging for other distant metastases isn't always required, as they're uncommon without these other two sites. If chest X-ray is positive, then a CT of the chest, abdomen, and pelvis should be done, as well as a brain MRI. Sydney, how is GTN staged?
A formal stage is assigned to GTN using FIGO staging. Stage 1 includes disease limited to the uterus. Stage 2 includes extension to the adnexa or vagina, limited to genital structures. Stage 3 includes pulmonary metastases with or without pelvic involvement. And lastly, stage 4 covers any metastatic disease outside of the lungs, pelvis, or vagina. But Maya, I've heard that stage doesn't really dictate treatment regimens for GTN. So how does FIGO staging differ from the WHO score? Which is more important prognostically?
You're right. Anyone with GTN will get a FIGO stage as well as a WHO score. The WHO score is more prognostic and ends up helping guide treatment decisions. This scoring system is complicated, so I feel like I always end up looking at the tables to remind myself. But hit me up if you want to hear the song I created to learn this for creogs in residency. The big takeaway is that a score less than 7 indicates low-risk disease, which is typically treated with single-agent therapy, as it's unlikely to have resistance to single-agent therapy. The WHO scoring system is most helpful for patients with stage 2 to 3 disease, where it's less obvious if they're high or low risk. Scores greater than or equal to 7 indicate high-risk disease, with risk of resistance to single-agent treatment. These patients require combination therapy. There's a subcategory of high-risk disease with a score greater than or equal to 12, which is called ultra-high-risk disease. This group has the worst prognosis. They often have a non-molar prior pregnancy, and they're more likely to fail multi-agent chemo. The components of the WHO score are age, with 40 as the cutoff, type of antecedent pregnancy, time from previous pregnancy to their GTN diagnosis, pretreatment serum HCG, largest tumor size, including the uterus, location of metastases, number of sites of metastases, and previous failed chemo. In each of these categories, you get a score of 0 to 4. If you don't have a chart or table with the specific scoring handy, you can usually eyeball if a patient will be above or below the cutoff of 7. Worst prognosis comes with older age, a previous term pregnancy, longer time to diagnosis, higher HCG, larger tumors, and more sites of metastases. The liver and the brain are the worst sites of the metastases, and lung mets actually get a score of 0 because they're so chemoresponsive. The WHO scoring system cannot be applied to intermediate trophoblastic tumors like PSTT and ETT. We'll discuss their workup later. Sydney, can you walk us through the treatment of low-risk GTN?
Low-risk GTN, so any patient with a WHO score less than 7, is typically managed with either single-agent methotrexate or dactinomycin. There isn't clear data on which agent or which dosing schedule is best. GOG 174 was published in 2011 and randomized patients with low-risk GTN to pulse dactinomycin versus weekly methotrexate. Complete response rates were pretty low for both regimens, but were better with the pulse dactinomycin, 70% versus 53%. A Cochrane review published in 2016 concluded that there was moderate certainty evidence that methotrexate was more likely to fail than dactinomycin in the frontline setting, with dactinomycin more likely to lead to a primary cure. However, most of the trials in this Cochrane review utilize weekly methotrexate, which has now been established to be less effective than daily or every other day regimens. NRG GOG 275 was then published in 2020. This was a phase 3 trial of pulse dactinomycin versus multi-day methotrexate for low-risk GTN. Providers could choose between a 5 or 8-day regimen for methotrexate. Recruitment was low and the trial was closed early with less than 30 patients in each arm. The cure rate for the different regimens was not significantly different, with an 88% cure rate with methotrexate and a 79% cure rate with actinomycin D. Survival rate was 100% and there were 2 recurrences in each arm. Quality of life did not differ between the arms. The takeaway from these studies is that there are many options for treatment. Many providers start with methotrexate as there is generally a better side effect profile, which we'll discuss in a bit. Methotrexate can be given as a 5-day daily or 8-day every other day regimen, repeated every 14 days. The weekly IM methotrexate regimen is no longer recommended as the success rate is really low. In fact, 12% if the prognostic score is 6. Dactinomycin can be done as a 5-day regimen or a large dose pulse every 2 weeks. Maya, how do the side effect profiles differ for these 2 agents?
Methotrexate is an antimetabolite, like gemcitabine, which we covered in episode 7, cytotoxic chemotherapy for uterine cancer. It works as a folate antagonist. Side effects occur with higher doses of methotrexate, so they typically aren't seen when you're using it for the treatment of ectopic pregnancy. Hepatic and renal toxicity are the most common. With the doses used to treat low-risk GTN, the most common side effects are stomatitis. With higher doses, there's more side effects. Hepatotoxicity, including potential necrosis and cirrhosis, is possible, as is renal toxicity. Methotrexate is cleared renally, and so caution must be used in patients with renal disease. There's a risk for drug buildup and increased systemic toxicity. Nephrotoxicity can be minimized with hydration and alkalinization of the urine. GI toxicity, including nausea and vomiting, are more common with higher doses. You can also get dermatologic side effects, including photosensitivity, so avoiding sunlight is important during treatment. Pulmonary sensitivity can also occur, usually in the form of a hypersensitivity pneumonitis with high-dose methotrexate. Finally, patients with high-dose methotrexate can develop acute or subacute encephalopathy, which typically resolves spontaneously. Leucovorin is a folate analog which counteracts the toxic effects of methotrexate in normal tissue. It's crucial to use this if you're administering high-dose methotrexate, but typically isn't needed with doses less than or equal to 250 milligrams per meter squared. Methotrexate, compared to actinomycin, has less nausea and vomiting and alopecia, but more mucositis and eye pain. Actinomycin D, or dactinomycin, is the other option. It's an anti-tumor antibiotic. We mentioned already that methotrexate generally has a superior side effect profile. Actinomycin is more emetogenic than methotrexate, can cause alopecia, and is a vesicant, so care needs to be taken to avoid extravasation. However, it's a good alternative if methotrexate is contraindicated due to renal or liver dysfunction. While actinomycin D can cause hepatic dysfunction, it's less likely than with methotrexate. There's a rare risk of severe dermatologic toxicity like Stevens-Johnson syndrome with dactinomycin, and the risk of myelosuppression is similar to that with methotrexate.
Is there anything else to consider for primary treatment of low-risk GTN?
Yes, we wanted to talk briefly about the role for repeat curettage for postmolar GTN. Traditional and typical practice is that it's not recommended. However, there are a couple scenarios in which it might be helpful. If a patient is having persistent vaginal bleeding causing a lot of symptoms, a second curettage can be therapeutic. Sometimes a second curettage is done if it's unclear if the first curettage was complete in evacuating tissue. Finally, for low-risk GTN with no extrauterine disease, in some cases, a second curettage and serial monitoring of HCG could avoid the need for chemotherapy. GOG 242 was a phase 2 trial which followed 60 patients with low-risk GTN who had a second uterine curettage. The cure rate was 40%, and adverse events were low. Hysterectomy is another option, which can be considered for patients no longer desiring fertility with uterine confined disease. In a retrospective study published in 2017, there was a 66% cure rate with hysterectomy for uterine confined disease. Sydney, how do we know if our first-line chemotherapy is working or not?
HCG values, like in diagnosis, tell us whether patients are responding to treatment or developing resistance. Generally, HCG levels are measured every 2 weeks during treatment at the start of each cycle. Once HCG has normalized, chemotherapy is usually continued for 2 to 3 more cycles, and then HCG levels are monitored monthly for 1 year. It's important to make sure patients have effective contraception during their follow-up so that a new pregnancy doesn't confuse the measurement of HCG values. Traditionally, it was taught that oral contraception was necessary due to suppression of the HB gonadal axis, but recent evidence has demonstrated that the progesterone IUD is also a safe option. Wait until the HCG has normalized before placing a progesterone IUD. Diagnosis of chemotherapy resistance occurs when there's a rise in HCG greater than 10% over 2 chemotherapy cycles, or a plateau of HCG over 3 chemotherapy cycles less than 10%. We're still working on figuring out how to predict who might not respond to initial single-agent therapy. Patients with really elevated HCG, for example, greater than 400,000, even if no metastatic disease, often don't respond to single-agent chemotherapy and will likely benefit from upfront multi-agent chemotherapy. If patients have metastatic disease or choriocarcinoma and an HCG greater than 150,000, most will ultimately need multi-agent, so considering this from the start is also reasonable. Maya, how do we treat patients who develop chemotherapy resistance?
Patients with resistance to first-line single-agent therapy can be treated with single or multi-agent second-line therapy. Decisions on which type to switch to aren't based on any randomized controlled trials. Generally, if patients had a good initial response to therapy but then have an HCG plateau, or if they have dose-limiting toxicity to the first-line regimen, you could consider switching to a second single-agent therapy, like switching to dactinomycin if you started with methotrexate. In this scenario, retrospective reviews have shown a high complete response rate of about 75% with second-line single-agent therapy. If patients responded poorly to the first-line therapy, or if they respond initially but then have quickly rising HCG levels, then switching to a multi-agent therapy might be indicated. Emico, which includes etoposide, methotrexate, and actinomycin D, alternating with cyclophosphamide and vincristine, is the typical choice in this scenario, and cure rates are close to 100%. Again, HCG values are measured every 2 weeks during treatment with second-line therapy. If patients respond initially and then recur or relapse, it's really important to restage them to help decide which regimens will be effective. Sydney, can you walk us through the high-risk GTN treatment options?
Absolutely. Recall that high-risk disease is diagnosed with a WHO score greater than or equal to 7, with ultra-high-risk patients having a score greater than or equal to 12. This is a relatively rare diagnosis, accounting for only about 6% of all post-molar GTN. Cure rates are still very good, with about 90% cure rate for all high-risk disease. Patients with stage 4 disease, especially with liver and brain mets, have a poor prognosis with about a 70% cure rate. Chemotherapy for high-risk GTN is all multi-agent. Current options for first-line regimens include Emico and EMA-EP. This substitutes etoposide and cisplatin for the cyclophosphamide vincristine of Emico. Historically, other regimens like MAC and Chemoka were more frequently used. Multi-agent chemotherapy is challenging to administer, typically requiring inpatient administration. Emico became the standard of care due to high cure rates and relatively tolerable toxicities. The largest study informing the use of Emico was a prospective study published in 1997, which included 272 patients and demonstrated a 5-year survival of 86%. More recently, there is some data that EMA-EP may be more effective in ultra-high-risk disease than Emico, although it is more toxic. In patients with ultra-high-risk disease, sometimes induction chemotherapy with low-dose etoposide cisplatin is performed, as starting with full regimen Emico can result in tumor collapse, which can have sequelae such as hemorrhage, metabolic acidosis, multi-organ failure, and can result in early treatment-related death. In a study by Alafrangis published in 2013, induction with low-dose etoposide cisplatin reduced the rate of early death to less than 1%, compared to 7% of their historical cohort. Maya, what about patients with CNS metastases and those who don't respond to initial multi-agent chemotherapy?
For patients with CNS metastases, which make up about 20% of patients with choriocarcinoma, there's multiple options to enhance your chemotherapy regimen with a better chance of cure. High-dose methotrexate is usually incorporated into the regimen with doses of 1,000 milligrams per meter squared. When giving high-dose methotrexate, it's important to add additional oral doses of leucovorin. Intrathecal methotrexate is another option in the setting of CNS metastases. The cure rate with intrathecal methotrexate is up to 85%, as opposed to around 70% with high-dose IV methotrexate. In the US, this isn't really done. However, in the UK, it's a standard component for patients who have CNS metastases. Finally, stereotactic brain radiation can also be added for intrathecal metastases. Salvage chemotherapy describes chemotherapeutic regimens delivered after incomplete response or relapse after initial multi-agent chemotherapy. These are typically regimens which involve etoposide and a platinum agent. Surgical resection of tumors, especially if it's oligometastatic disease, can be employed as well. If patients initially were given Emico, a switch to EMA-EP results in a complete response rate of about 75 to 85%. There are many other salvage chemotherapy options, including Taxol cisplatin, alternating with Taxol etoposide, BEP, and many others. Any regimen employing etoposide and cisplatin needs to incorporate G-CSF to prevent neutropenia, which can be profound and result in treatment delays. Factors such as a high initial HCG at the beginning of salvage therapy, higher number of metastatic sites, and a WHO score greater than 12 are associated with worse prognosis. Sydney, can you finish up this portion of our discussion by talking about other regimens and emerging agents which are being employed in the treatment of high-risk and treatment-resistant GTN?
Be happy to. High-dose chemotherapy in combination with stem cell transplant can be used for refractory or poor prognosis disease. There are multiple high-dose chemotherapy regimens, often combining high-dose etoposide with a platinum agent, with sometimes additional agents like Taxol, cyclophosphamide. In a study of 32 patients with refractory choriocarcinoma or poor prognosis PSTT/ETT, high-dose chemo in combination with blood stem cell support resulted in a complete response in 7 out of 32 patients. This regimen, of course, can be quite toxic and does work better in patients with low HCG levels. Immune checkpoint inhibitors are also emerging as promising agents in the treatment of GTN. GTN cells strongly express PD-L1. In a case series by Gorani et al. In 2017, out of 4 patients with drug-resistant GTN, there was a durable response seen in 3 of 4 cases treated with pembrolizumab. Pembrolizumab and nivolumab, another anti-PD-1 agent, are preferred agents if using immunotherapy. Avelumab has also been studied in small case series and is another option listed by the NCCN. There isn't a clear consensus or understanding to date of when immunotherapy is best incorporated, likely after the first or second failure of chemotherapy regimens. There are multiple studies, either ongoing or planned, which are attempting to better delineate the role of immune checkpoint inhibitor therapy in the treatment of GTN. Finally, surgery can sometimes be employed for high-risk chemo-resistant disease with incorporation of IR procedures for areas prone to hemorrhage. Maya, let's shift our discussion. Can you tell us about intermediate trophoblastic tumors?
Of course. Intermediate trophoblastic tumors encompass placental site trophoblastic tumors and epithelioid trophoblastic tumors. These are rare tumors, making up only 0.23% of all GTD. They're generally slow growing, HCG is not as reliably elevated, and these tumors are less chemoresponsive. They often present with AUB or sometimes amenorrhea. At time of diagnosis, 30 to 50% are metastatic. The lungs are the most common site of metastases. They have some unique features on histopathology. PSTT tend to express CD146, aka MELCAM, diffusely, as well as human placental lactogen. ETTs express P63, and greater than 50% of their cells will be cyclin E positive. ETT are more weakly expressive of MELCAM and human placental lactogen. Prognosis is still relatively good, with an 80% 5-year survival. Advanced disease stage and prolonged interval from last known pregnancy are important prognostic markers. Survival for locally confined disease nears 100%. Treatment of ITT is different than other forms of GTN. These tumors are relatively chemoresistant, like we mentioned, and so surgical treatment takes the forefront. Hysterectomy with self-injectome is the standard treatment. For apparent uterine confined disease, pelvic lymph node biopsy is performed, while for metastatic disease, debulking with resection of all metastatic implants is the standard. For metastatic disease more than stage 1, chemotherapy is added adjuvantly with a platinum-based regimen. Chemotherapy can also be considered for stage 1 patients with poor prognostic markers. Options include EMA-EP or multiple other regimens, which are all listed in the NCCN guidelines. See the guidelines for options and dosing. After primary treatment, HCG can be used for surveillance, especially if it was elevated during the initial diagnosis, although it's less reliable than in other forms of GTN. PET-CT is usually added at completion of chemo and every 6 to 12 months for up to 3 years. Recurrences can happen years after initial treatment. If ITTs recur, treatment options include reattempting first-line therapy, using other high-risk GTN regimens, or best supportive care. Sydney, can you finish us off by talking about the sequelae of some of these more aggressive chemotherapy regimens?
Yes. The main risk that we worry about, especially with these high-dose chemotherapies and multi-agent regimens, is the risk of secondary cancers. There's an increased risk of oral cancers, melanoma, meningiomas, and leukemias. The risk of leukemia increases significantly after a lifetime dose of 2,000 milligrams of etoposide. That's equivalent to 10 cycles of standard dosing Emiko. There's also a risk of premature menopause, which is less than 10% with methotrexate and similar to the general population, but with Emiko treatment is about 13% prior to the age 40 and 36% prior to age 45. That is all we have for you today. We hope you learned something on today's episode of Ready, Set, GYO, a podcast for Gyn-Onc Fellows. Here are your key takeaways from today's episode.
Gestational trophoblastic disease includes complete moles, partial moles, and gestational trophoblastic neoplasia. Gestational trophoblastic neoplasia describes malignant subtypes of GTD, including invasive moles, choriocarcinomas, and intermediate trophoblastic tumors, which encompass placental site trophoblastic tumors and epithelioid trophoblastic tumors.
In GTN, FIGO stage is not a great prognostic marker. Thus, a separate system, the WHO score, is used to determine prognosis and appropriate treatment. A score less than or equal to 6 is considered low risk, and a score greater than or equal to 7 is high risk. Contributing factors in the system include age, antecedent pregnancy, interval from index pregnancy, pretreatment HCG, largest tumor size, site and number of metastases, and number of prior unsuccessful chemotherapy regimens.
While multi-day, 5 or 8-day methotrexate regimens are typically used as the first-line therapy in low-risk GTN due to the favored toxicity profile over actinomycin D, there's not convincing evidence that one is superior to the other. Trials comparing the two have used different dosing formats. GOG 174 showed improved efficacy of actinomycin D over methotrexate. However, the dosing schedule of methotrexate was weekly, which has now shown to be less effective. GOG 275 compared pulse actinomycin D versus multi-day methotrexate and showed no difference in complete response between the two regimens.
HCG monitoring and response assessment is the same for first-line and second-line therapy. Patients should have an HCG test every 2 weeks corresponding with the start of each treatment cycle, should have an additional 2 to 3 treatment cycles once the value normalizes, and should have a monthly HCG test for a year after treatment. Contraception is especially important in this setting so that proper post-treatment monitoring can be carried out.
First-line therapy for high-risk GTN differs from that of low-risk GTN. Emico is the most often used first-line therapy in high-risk GTN. EMA-EP or EP-EMA can also be used. If a patient has ultra-high-risk GTN with a large burden of disease, induction chemotherapy with etoposide and paclitaxel should be considered.
Intermediate trophoblastic tumors include placental site trophoblastic tumors, PSTT, and epithelioid trophoblastic tumors, ETT. These tumors tend to have more lymphatic spread, are relatively chemoresistant, and may have a heightened role for surgery compared to other GTN subtypes. In addition, these tumors secrete less HCG, so HCG tends to be a less reliable tumor marker.
This has been another episode of Ready, Set, GYO, your source for all things gyno.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at ReadySetGYO.
To support us and our production of future episodes, check out our Patreon at ReadySetGYO.
This episode was recorded by Sydney Ersch and Maya Gross. Our sound editors are Brogan Brown and Kylie Knight. Our media and website manager is Sky Jacobson.
We'd like to thank Dr. Allison Garrett, faculty at UPMC Magee Women's Hospital, who reviewed the content of this episode for accuracy and completeness.
Sydney and Maya signing off.